Next is rhabdomyolysis. So rhabdomyolysis can cause acute pulmonary necrosis. So we have muscle. If there is a muscle breakdown, that will release myoglobin, which is toxic to the kidney. So crushing injury, immobilization due to coma, fall, recent surgical procedure, high voltage electricity injury, third degree burn. So anything which is causing muscle damage, severe exertion, seizure, delirium tremor, heat stroke, severe hypothermia, drug intoxin like cocaine, amphetamine is most common, statin, neuroleptic malignant syndrome, infection, especially in old age, people who are in 80s and 90s. I saw some patient who presented with influenza A or B. When I check, they have kidney injury. When I check creatinine level, creatinine kinase level, it was high, and patient had rhabdomyolysis. DKA, pheochromocytoma, hypo or hyperthyroidism, severe electrolyte abnormalities. So signs and symptoms, they will complain of aches and pains in the muscles, and they will be feeling weak and fatigued. So sometimes they can have non-specific symptoms like they will say fever, abdominal pain, nausea, vomiting. But the common symptom, muscle aches and pains, tiredness, fatigue. Workup wise, so you'll start the basic workup, you'll get creatine kinase level will be high. You can get urine analysis, which will be positive for blood because of myoglobin, presence of myoglobin from muscle, but negative for RBC. That indicate rhabdomyolysis. Creatine kinase elevated, hallmark of rhabdomyolysis. Hyperkalemia, most common in, so these patients with rhabdomyolysis, they can have abnormality in electrolytes. So when the muscle breakdown happen, it will release electrolyte. Potassium will be released, phosphorus will be released, uric acid will be released. So phosphate can combine with calcium and decrease calcium can occur, hypocalcemia. So all these can lead to hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia. So these are the electrolyte abnormalities which we have to treat accordingly, according to their level. Myoglobin is toxic to the kidney and can cause AKI, so we have to give them fluid. So complication, one other complication is compartment syndrome, because these patients with rhabdomyolysis require a lot of fluid. And let's say if the patient has a bone fracture, which is causing rhabdomyolysis, because bone fracture can cause muscle injury too. If you're giving them a lot of fluid after surgery, because long bone is the area of closed space, and giving fluid can cause compartment syndrome too, so be careful with that. Severe rhabdomyolysis can cause DIC because muscle will release thromboplastin, which is prothrombotic, and can cause DIC. Treatment. So you have to give them a lot of fluid. So your starting point will be at least 200 cc an hour. It can be even 250. And your goal is to maintain urinary output of 200 to 300 ml per hour. Your goal is to bring down creatine kinase level less than 500. It's not 5,000, it's less than 500. So number one is fluid. Number two, there is no evidence of alkalization of urine. So you should not do forced diuresis. Use of mannitol is limited. If there is a kidney failure, then dialysis is indicated. So the main treatment is IV fluid, 200 to 250 cc an hour, to maintain the urinary output of 200 ml per hour. Now, what are the metabolic abnormalities? We already discussed. So if the potassium is very high, treat accordingly. Uric acid is high, especially greater than 8, you can use allopurinol. If calcium is too low and patient is symptomatic, you can give calcium supplement. For kidney injury, give them fluid. So this is rhabdomyolysis.